Hi, I'm Peter Mitchell from radiopedia.org, and in this last episode of our stroke series we will be discussing endovascular intervention on ischemic stroke. The role of endovascular therapy for thromboembolic stroke continues to evolve rapidly and remains controversial with little consensus on inclusion criteria and outcome benefits. Various strategies have been tried over the years which can be divided broadly into intra-arterial thrombolysis, mechanical clot disruption, and clot retrieval. Up to the mid-1990s, management of thromboembolic strokes was purely supportive, aimed at minimising secondary injury resulting from swelling, stroke extension, and hemorrhagic transformation. Early work with intravenous thrombolysis was encouraging, and as early as 1990, administering concentrated thrombolytic agents, urokinase, streptokinase, or TPA, via catheter directly into the occluded vessel or into the clot was employed. This was often accompanied by mechanical clot disruption using catheter, wire manipulation, or later inflation of a small angioplasty balloon within the clot. These were anecdotally effective but did not result in any appreciable outcome improvement in trials. In 2001, the first clot retrieval device, concentric retriever, was approved by the FDA. The Mercy device was a small corkscrew-like device which was introduced into the clot and the clot pulled back into a guiding catheter. Moderate success was achieved with this device, however recanalization rates remained low. In 2012, a new type of device became available, Solitaire, which comprised a relatively open mesh stent attached to a wire, hence retrievable, originally designed for use in treating intracranial aneurysms. Let's now have a look at a fairly typical case. This 60-year-old male patient presented to our emergency department with a right-sided hemiplegia which had a sudden onset only 2 hours earlier. The initial non-contrast CT demonstrates no evidence of hemorrhage, but a hyperdense left MCA, confirmed on CTA as an M1 segment occlusion. There is no convincing grey matter hypoattenuation, an important negative, as loss of grey-white matter differentiation suggests an established infarct. CT perfusion demonstrated prolonged mean transfer time, but no significant abnormality in cerebral blood volume. This is consistent with a large ischemic penumbra. In other words, most of the area supplied by the now occluded vessel has not yet died, being supplied by collaterals, but is at risk of infarction if the vessel is not opened. The patient was taken to the angiography suite and a left common carotid injection confirmed complete occlusion of the cervical supraclinoid internal carotid artery with only external carotid flow present. Note, only a small amount of contrast pools in the carotid at the base of the skull. At this point, a guiding catheter was passed through the occluded left internal carotid artery, and with the aid of a wire, the M1 clot traversed by the Solitaire device. The wire was removed and the outer catheter withdrawn, deploying the device. A few minutes are allowed to pass, during which time some blood can already pass through the clot and reperfuse the brain distal to the occlusion. This is sometimes referred to as giving the brain a drink. Once the device is well incorporated into the clot, it is pulled back, along hopefully with the clot. Here we can see the clot stuck on the device, and angiographic images of the internal carotid demonstrate complete recanalization. Suction is applied to the balloon tip guiding catheter in the internal carotid artery, increasing the chance of successful clot withdrawal and minimizing the chances of distal embolus. Prior to finishing the procedure, a stent was placed across the critical proximal internal carotid artery stenosis. A follow-up CT 3 days later demonstrates an excellent outcome with no appreciable established infarction. The key to successful recanalization, while avoiding the complication of hemorrhagic transformation, is good patient selection. Although inclusion criteria vary from hospital to hospital and trial to trial, generally a patient should have a clearly determined time of stroke onset within 4.5 hours of the start of treatment. A non-contrast CT should demonstrate little established infarction. Additionally, if available, CT perfusion demonstrating a small infarct core and a large penumbra is ideal, as this minimizes the volume of tissue at risk of hemorrhage while maximizing the amount of salvageable tissue. In carefully selected patients, successful clot retrieval can be achieved in up to 80%, and in these patients, at least anecdotally, outcomes can be dramatically improved, although attempts at establishing that there is a measurable outcome improvement has been difficult in the trial setting. So in summary, modern stroke management now includes the ability to remove the causative clot endovascularly. Key to success is careful patient selection and prompt transfer of the patient from the emergency department to the angiography suite.